Hello, all, and welcome to week 2 of Public Health Policy Lab. This scenario was given to you a week back, and I have put it on screen for you. So, let's dive deep into community med with me, Dr. Deepika Bishnoi, your very own community physician. Let me put you in the immunization officer's chair. And what we have here is 2.1 million people, of which 62% is rural, and the measles and rubella elimination campaign is live, as you can see. Target is given to us of 95% immunization, and this district is at 71, which is last in its block. So there are three blocks and three different diseases and three strategic options on the table, which are, as you can see, coerce, persuade, or reallocate. And the immunization officer can pick one, not all three. So let's see what I'm thinking and what I'll actually do. We'll divide it into parts. First, let's diagnose what's happening. There is block X. There's a WhatsApp voice note that claims that this MR vaccine is causing sterility for the girls. 340 families have refused, and now the school principal says that he wants a written parental consent before he allows any vaccination camp, and the most parents won't sign it. So let's see this clinically. You have to tackle it by telling that the MR vaccine is live attenuated. It does not affect your fertility. In fact, the rubella component actually protects the future mothers from the congenital rubella syndrome, which is blindness, deafness, heart defects in newborns. And the irony is so painful that a vaccine that will prevent birth defects is being rejected because it's rumored to cause sterility. Now, administratively, there's not like an information gap, but it's a big disorder. It's like the headmaster is not saying that he wants consent because he knows the law or anything. He's asking consent because he's scared of this parental backlash that will come to him, and because he's lost somewhere some trust in this system, and he's outsourcing his liability to a piece of paper that's a consent form. And the MR campaign guidelines do mention that invitation letters can be given out, but nowhere a written consent is a barrier. So this is more of a procedural blockade. Coming to block Y, three ashas were chased out last week, and Sarpanch of the Gaon has announced that outsiders with vaccinations are not welcome, and so these ANMs are afraid to return. But this is not vaccine hesitancy. This is more of like community resistance coming up. This is rooted that they have mistrust or they don't have trust in the health system. A similar thing had happened in the polio era, but Social Mobilization Network, which is a SMNet, to that found that over 59% of households in Uttar Pradesh and Bihar cited that lack of trust in the health system and misbehavior of service providers. So, as you can see, resistance was not like about the vaccine, but it was about who was carrying it. And if we use police escort or something legal, then there will be some we'll win the war today, but I don't think it will be good for the long run. And what will happen in the next round is that it will be worse hostility. People or the community will not be with you. What is happening in Block Z, or it's that the coverage is 89%, good on numbers. But Asha says that she estimated these household numbers because the micro plan was never updated. And this means that the denominator is only totally wrong. It's fictional. These numbers are fictional, and on paper there might be vaccination of the same child twice because the calculation is wrong, and the actual zero dose child, the one who really matters for this elimination of measles rubella, it's invisible. And the immunization officer handbook of MHFW also states that microplans must be built from house to house surveys, Anganwadi records, and school lists. So if we don't know where people live, we don't have a campaign. We just have numbers and we just have performance. It's just 89% on paper. Let's come to the part 2 where we choose from these options. I'm definitely rejecting the first option, which is using coercion. Administration, law and order, they might help you mandate school participation, but it's not really something that will help you. Because as the Epidemic Disease Act of 1897, we know that it's not a comprehensive, it's not a legal framework for mandating vaccination. Indian courts have told that coercive vaccination will affect personal liberty, bodily autonomy, and any coercion, it should not be done until and unless it's legitimate, suitable, necessary, and balanced. And sending police into the village that has already chased out its ashas, it's actually failing the community. So when communities own the decision, the refusal rates will stay low, which is what we saw in SMNet during the polio time period. And SMNet, that is a social mobilization, had reduced this resistant households by 77% in Bihar and 86% in UP. So it's not by force, but it's by trust. And option A is definitely out of the table. Administrative authority should only be used to coordinate between the institutions, like, telling the block education officer that I need schools to participate in this program. That's where it's usable. Coming to part 3, we can use the second option, which is persuade, but only for blocks X and Y. It is a slow process. It may not get us to 90% by the date, but it's the only strategy that will help the community have trust in you. And for block X, the counter message cannot come from the administration. It cannot come from the immunization officer. It must come from the community, which the people already trust. And UNICEF evaluation also told that advocacy by faith leaders at national level, like a local Maulvi or a Pandit who has vaccinated their own child, they're speaking to the mothers and the parents. You have a recovered measles a patient, or even better, a mother whose child had congenital rubella syndrome. It's like, it tells you it's safe. It tells that there was a survivor, they've lived through it. And even the SMNet model, which was there in the polio, they during that time they had coordinated such mothers meetings, they had coordinated mosque and temple announcements, and conducted classes in madrasas and schools. And these people came from the same community, they spoke in the same dialect, they have the same faith. And so in UP during the polio time, 90% mobilizers were women. That's not accidental. Coming to block Y, the first thing would be withdrawing the ANM. Her safety is non-negotiable. You cannot send her back until the Sarpanch invites. Finding a community mobilization coordinator from the same village, same caste, same religion, someone who speaks their own language. They don't have to carry the vaccines, but they have to carry conversations, which is really important right now. They have to visit the Sarpanch personally, and only when the Sarpanch has had a talk with these mobilization officers and then they invite us back, then only we will be able to go back. This might, we might miss the deadline, but we will not miss a zero dose child. Coming to part 4, the option C is suitable for block Z, because it says you have to stop chasing the 95% district average. Okay? Redirecting the teams to verify the microplan is right now the most important. We have to find out these zero dose blocks X and Y will still remain undercovered. It's okay, but block Z, you have to actively work on the data, because that itself is, like, there is no denominator. You don't have a factual data, and the MR campaign cannot work if you don't have the data. You might be, vaccinating a child twice, and that's just showing up as numbers. And so, like, taking out the coverage areas, doing targeted mop up, diagnosing the children, rather than hiding it behind the numbers. So what we do on the ground is we halt the new vaccination until we verify the microplan. We have to halt it. We have to deploy a team, maybe a ANM, an Anganwadi worker, a supervisor. They're doing these house to house visits. So after flagging the duplicates, we flag vaccinated but not resident of that area, flagging the zero dose but it's still present, and we have to present the correct denominator to the DHO before the review. If true coverage is going to be 58%, let's just say an arbitrary number which is less than the on paper number, then it will be what it is. The only way how we can reach the missing children would be by doing this, by halting it currently, updating the microplan, and getting the real denominator before putting our resources into it. So what do we tell the higher ups? That was a part of the question, that how do you that's a difficult conversation to have. The DHO wants the 90%, and we're going to tell him that it's not possible. It's not possible until we lose trust in the community, lose the community's trust in the health system that is built. It's not like District B does not have a single problem. All the 3 blocks which were mentioned, they were sort of like 3 different problems. It's a trust collapse, it's a data integrity problem, it's denominators are wrong. Our coverage rates would be meaningless if we did not go and check the microplan. So coercion is not an option, definitely not going for that option. Block Y and block X, they, it will, from resistance they'll go to violence, and it'll just be something that will be difficult to manage later on. And like, in spite of that, we can be using some mechanisms like the social mobilization, SMNet during polio. We can, we don't want extension of the targets, but permission that we have to report honest data. The block C's problem would be it shows 89%. Why do we want to drop it to the actual number? Right? So authorization for a mop-up round after the microplan has been updated, that is something that needs to be worked on. Mobilizers for block X and Y, maybe from the same community, same district level, a local Maulvi or a pandit or a religious leader or someone who has a good say and hold over what the community does. And so this is what we tell the higher ups. And what do we do? For block X specifically, we have to network where this WhatsApp audio message or social spread is happening. We don't have to confront, we just have to need the information, and we have to talk to the school headmasters. We don't ask for waivers, we just, we ask them what would make them confident enough to allow the camp to happen. And we can maybe provide them with a MR fact sheet, which is a government authorized document, so that their liabilities and fear are, we can tackle that. And a mother's meeting can be held by a local mother, maybe who knows or who has a child who suffered from measles or who had congenital rubella syndrome in their infants, and they can talk directly with the community. For block Y, we definitely have to keep the healthcare workers outside. We cannot let them enter inside, because if their safety is hampered, then that's the last thing we want. We would identify a community mobilization coordinator from the same village, and we ask them to visit the sarpanch. We ask meeting with the local religious leaders who have vaccinated their grandchildren, someone who the community trusts. And only when the sarpanch will invite the people who vaccinate the children back, these healthcare, these frontline workers, then only we do that. And we schedule a session. For block Z, maybe we definitely halt the vaccination, because there's no verification for the denominators, and we do a house to house recount, we do cross matching with the registers, we find these real zero dose children, and we request a mop up after we have finalized the the actual numbers. And so what is the take home message in such kind of scenarios? Maybe it's not necessary that you take note of all of that, but remember these 5 R's from the district immunization crisis management. The first one would be recognize. You have to recognize the problem statement. It can be a failure, it can be a rumor, it can be hesitancy, it can be trust, it can be data. Everything needs a personalized tool. We cannot treat a data problem with a poster or a good IEC. Second R is refuse coercion. Definitely, coercion will not help us win in the long term ever. Third R is recruit local. You have to have your mobilizers or your faith leaders talking about they need to do the work for you. So take the example of the social mobilization net during the polio, and you can work with that. Fourth R is re-verify the denominator, which is a data problem which we saw in the above case, and house to house rounds can be done and the numbers can be updated. And the fifth and the last R would be reporting honestly. And the DHO can defend the truth at the state review, but he cannot defend numbers which are not there on in reality. So review meeting will come, DHO may be angry, he may be relieved, but he knows, he has trust in the immunization officer that they are not inflating the numbers, they are not burning the community trust for future, and they're not endangering frontline workers. Someday we will achieve the 95%, but it has to be real, it has to come as a real coverage which will be built on trust, which will be verified by the data, it will be owned by the community, and that is the only foundation on which the measles rubella elimination can be ever achieved. This is what I would do, and this is how it should be. And any coverage without trust it's just a number, and trust without coverage is a failure. So have to meet both of them, have to meet at the middle line. Thank you all for listening, and if you have any suggestions, any feedback, or if you have your own version of how you would tackle this, please drop it in the comments below. Have a wonderful day.